Afternoon, and thanks for asking me to talk this afternoon about the skin neglected tropical diseases from the Pacific perspective, and I'll also give you some of my experience of the Pacific Dermatology Training Centre. And I have no conflicts to declare. Two of my helpers are sitting in the audience today. I'd just like to do the acknowledgement of country, which is a very traditional Australian thing to do. And I just would like to begin today by acknowledging the traditional custodians of the lands from which we come from and meet today, and pay my respect to their elders, past, present, and emerging.
So, sorry to interrupt you. I just have to make a short announcement on behalf of the online participants. Please stay muted. Obviously, there's some people not muted or unmute themselves, or someone unmutes them. It's obviously disturbing. Sorry. Please continue.
Where do I point it at? Great. So the population of the Pacific this is the countries of the Pacific. It's about 14 countries, population of only about 13 million, excluding Australia and New Zealand. And you can see them on the map there. There are some others, including Kiribati, which is completely off the screen at the top. There's a population of about 9 million in Papua New Guinea, which is the most populous country, and the other 4 million are spread amongst all the remaining countries. And Fiji is the next most populous, with a population of nearly 1 million. So in this area, back in 2018, Papua New Guinea, with a population of 9 million, had 2 dermatologists, and Fiji had 1 who was non-clinical at that time, but a couple of doctors who had the diploma in dermatology from Thailand. Grand. So in response to that lack of regional dermatologists, after I've been doing research, there was a lot of push as to why, when we were going to set up bring more dermatologists, and the Pacific Dermatology Training Centre was opened in 2019 with a postgraduate diploma in dermatology and subsequently a master's in dermatology. And this is our team at the end of last year, with our graduates and our diplomas from 2024. So I'm going to just talk about the Pacific neglected tropical diseases, and scabies is doesn't matter. Scabies is my.
Doesn't work.
Where am I meant to point it at? Beautiful. Scabies is my first one. So this is a very classic Pacific view of scabies, caused by Sarcoptes scabii, and can become secondarily infected, as we all know. They say, it causes impetigo, soft tissue infection, septicemia, glomerulonephritis, rheumatic fever. But really, what did that mean? I didn't really understand what soft tissue infection due to strep was until last year. And when a 32-year-old woman presented to the clinic with a 2-week history of a rapidly progressing ulcer. She had a background of scabies, and that's her other leg on the other side, with little localized areas of impetigo. Streptococcus was isolated, and this was just this very, very rapidly progressing, very scary ulcer. So there was complete resolution with IV antibiotics, and she went home with a completely healed wound after 3 weeks. But the appearance and the speed of that gives you some indication as to why there's a 5% mortality rate with serious soft tissue infections. So the Pacific is full of ulcers, and for multiple reasons. So with the scabies work, when we look at this, we can see that when a systematic review was done by Lucia Romani of scabies, it was 10 years ago, but the situation remains the same today. We have Africa, Asia, South America, Europe, Middle East, and you can see that the Pacific has got a very high evidence of scabies. That's the community prevalence rate. That's not the local institutional rate. And in the national survey we did, it was a 23% prevalence rate of when we looked at 13,000 people over 75 villages. So quite scary. That research led to a bit of a panic in Fiji, and there was a thing that they needed to do some treatment trial. And so we were able to do this randomized mass drug treatment trial in Fiji, looking at comparison between 3 little village island clusters, and those clusters produced this set of results, and that showed a prevalence rate of scabies in community of between 30 and 40%, and with a mass drug treatment program with ivermectin, the rate after came down at 12 months' time to less than 2%. That was with oral ivermectin and for permethrin for the babies, and permethrin mass drug administration for also brought down a 60% reduction. So this was quite dramatic effect. Standard treatment regime was with permethrin, but not as a mass drug administration. So I'll go on now after. So those results from the Pacific, from Fiji about scabies, were then replicated across different countries, including Solomon Islands, Samoa, and Samoa, and more recently up in Kiribati. So with the fungal infections, including chromoblastomycosis, it's actually a kind of a syndromic thing. And when you learn about chromoblastomycosis, it's a bit confusing in the middle, but it's actually a group of different fungi which produce the same thing of the brown pennies on microscopy. They had the similar clinical picture, and that species needs to be determined by either PCR or by culture and microscopy. Early on, you just see a single small area which expands slowly with time, getting these hyperkeratotic plaques. It usually begins with a penetrating injury, so it means that the surface our surface microbiome and immunology is not able to keep the skin protected when it's penetrating an injury. And in the Pacific context, the reason we don't have any speciation of all of it is that there is no fungal diagnostic laboratories across all of these 14 countries, including anything other than microscopy done by the clinicians at the time. We're trying to establish a fungal lab in Fiji. So when we think about the chromoblastomycosis in the Pacific, how do you know or not know about this? You can imagine there's no dermatologist, so there's nobody to count the cases. So we did a review soon after the training program began, 6 months of retrospective review of 7,500 cases, and they're in a book in the nurses, and at the end of every case there's a diagnosis has to be written down by the doctor, a working diagnosis, and that working diagnosis is written in the clinic book. And by counting through and putting them all in an Excel database, we're able to find 16 clinical diagnoses where a clinical diagnosis of chromoblastomycosis was made. We need to chase up those to find out how many of them were actually confirmed on fungal microscopy and culture, which we're trying to do soon. So this is a gentleman who I only saw 2 weeks ago, 68-year-old man, 20-year history of increasing lesions on his legs. He had been in hospital and had some itraconazole. He'd been on pulse itraconazole for about 3 months, and although his skin improved, these are actually much smaller than they were in the beginning. But he was admitted with cellulitis, which was treated, and then he's being discharged home with his further itraconazole that he's purchasing himself. We did a simple skin scraping, which I was introduced to, which I didn't know you could do that it worked, because I always thought of the brown copper pennies in the dermis, but we did these scrapings on the surface, and that brown mess there is a large bunch of medlar bodies, and that was done from a superficial scraping. So it means that there's a new way for me as a dermatologist, thinking you could only do it by microscopy, is by doing it by scraping. Obviously, it means that there is fungus there, even if they can't see them on microscopy. So mycetoma is the same. It's a kind of a picture, a clinical picture, and it's due to different things, and they can actually be bacteria and fungi, and that can include Acinetobacter. So you get this picture of these painless swelling with sinuses and draining, and they have a discharge containing grains, can be caused by bacteria and fungi, and that patient came in when we were there last year. So mycetoma, although not recorded anywhere, does exist in the Pacific. So leprosy, Hansen's, chronic bacterial infection. These are all the really important neglected tropical skin diseases. So we've got our big group, and these are so important because of the way they destroy people's lives. So it primarily, as you know, affects the skin and peripheral nerves, with humans as the most significant, as the only significant reservoir. So this gentleman, the amazing thing I see in the Pacific is that they have an awful lot of multipacillary disease, and the ears, you know, they always say ears are affected, but they always seem to be affected in Fiji. I don't know, I have no idea why, but you can see this gentleman's ears have been actually got a lot worse than this after he had a large number of episodes of ENL. In the Pacific, the WHO guidelines are almost exclusively used to treat leprosy. So just to say that when we look at what's happened in the Pacific, so most Pacific countries have had leprosy elimination, however, not eradication, and a number of them have yet to fall under the elimination threshold as well. So in Kiribati, which is a little small, this weird kind of country that's in the North Pacific, and in fact it's got one island cluster here and one island cluster here, and the distance between those little islands is the same as the distance across Australia, but happens to be up in the middle of the ocean. All right, so these are so remote. And they, over the last 10 years, more than 2,000 cases of leprosy were identified in Kiribati, and that's of a nation population of 150,000 people only in Kiribati. So all the measures that have been ever proposed for keeping leprosy under control have been instituted, including mass drug elimination with rifampicin, anyway, doesn't matter, I can't think of any more, but they've all been done because this has just been a disaster, starting off with families and then communities and then a national MDA. So the issues eliminating leprosy in these small Pacific problems, they have a really weak health system with not much capacity. When they took away all the people skilled in leprosy, it was left to the primary healthcare, and there was no sustained education about the primary healthcare people to identify it. So it got missed for a long period of time. Scattered population of a big area and lack of specialist services. These are now being helped by Pacific Leprosy Foundation from New Zealand, having lots of doctors going over there and big programs. And the first dermatologist from Kiribati is the first potential dermatologist, if he passes exam from Kiribati, is in the third year of his training program. So he will go back, and he's doing things at the moment with leprosy and scabies. So lymphatic filariasis, another really important neglected tropical disease in the Pacific. So the main thing to think about with lymphatic filariasis is the global mass drug treatment programs for filariasis. A lot of them began around about the time in the Pacific where DEC and albendazole were used. So it's, mosquito, fine. What I found interesting about lymphatic filariasis from a dermatology point of view is that, in fact, the microfilariae are in the blood lymphatics, and when they land in the lymph nodes or wherever they land and make the the adults are actually between 4 and 6 centimeters long and in a curl. And as part of the inflammation they induce, it's a big IL-17 process which causes the lymphatics to dilate. So it's not only obstructive, but it actually causes actual dilatation of the lymphatics as an active process as well. So although the parasite damages the lymph system, most infected people remain asymptomatic and will never develop skin problems, clinical problems. So what do they get? They get either lymphedema, fever, lymphedema. They call it elephantiasis, but there's, as you know, with lymphedema, there's a large scale which we sometimes use to record the level of lymphedema which the people have, and also hydrocele. So it's an extremely socially destroying condition. So in the Pacific, the Pac Health program was established 1999, and they used DEC and albendazole. And there was a little trial of albendazole and ivermectin in Samoa in around about in that same kind of time. So you can see here that in the beginning, filariasis was found all the way across the Pacific, and after periods of treatment, the number of countries which have gone red, that are still red, is diminishing, but there needs to be lots of steps in that process for confirming elimination, apart from reduction of microfilariae found in the blood. Just got to be less than 1% in high-risk areas to be declared a non-likely to be public health problem. So yours is still seen a lot in the Pacific. There was an enormous amount in Papua New Guinea previously. Chronic bacterial infection caused by Treponema pallidum. So same, or very, very closely related to syphilis. So some of the things, and in fact on blood tests, you can't tell whether somebody's had yours or whether they've had syphilis. So humans believed to be the only reservoir.
Sorry to interrupt.
Yep.
We need to come to an
Okay.
end.
And that's it. So there's yours, and it was one of the first diseases to have MDA. Broadly ulcer found in the Pacific. In Australia, there's a poster that we have about the training program, and thank you. Okay, great.
Thank you so much for this wonderful talk, and I'm really sad to interrupt and to shorten you, because it is really interesting what you have to tell, and we would have loved to continue listening to you, but we have to keep in time a bit. And